Hi, this is Giuseppe Argenziano from Naples, Italy, and today I would like to speak with you about atypical melanocytic lesions. What I mean with atypical melanocytic lesions is basically a type of lesion which is histopathologically in between a nevus and a melanoma. So, with subtle melanoma criteria which are not enough for the pathologist to diagnose the lesion as a melanoma. This is a kind of scheme that we can use when we read a histopathologic report. On a histopathologic report, you can find a clear-cut diagnosis of a nevus, meaning a junctional nevus, a compound, a dermal, or blue, or spitz, or whatever. So the pathologist is just telling us that he knows that this is a benign lesion. On the opposite side, when he clearly declares that this is a melanoma, it means that he knows that 100% the lesion it's looking like a melanoma. But in between, there are two other types of reports. When the pathologist is speaking about nevus, but with an additional word like atypical, spitzoid, dysplastic, it's just the pathologist is just telling us, I think it's a nevus, but I'm not sure 100%. And finally, when he avoid using the term nevus and then he uses the word atypical hyperplasia, atypical melanocytic proliferation, or atypical tumor, or meltamp, or sampus, these are all words telling us basically that the pathologist thinks that he is looking at the melanoma, but he is not sure 100%. Let me give you a few examples of the atypical melanocytic lesions defined as such by the pathologist in our collection. Basically, we are speaking about 40 lesions in 10 years. So it's not so frequent that the pathologist is completely doubtful about a lesion. What is also extremely nice is that among these 40 typical melanocytic lesions histopathologically, most of the lesions were located on the back of men or on the legs of women. But of course, it's possible that these kind of lesions are located everywhere, including special sites, and I would like to give you a few examples. Most of them are basically, as I told you, melanomas, that histopathologically show very subtle malignant criteria. So the pathologist is not able to name the lesion as a melanoma, as a clear-cut melanoma, okay? But anyway, they are excised because the clinician thinks that it's a suspicious lesion. Why? Because clinically and dermoscopically, they look atypical, okay? So let's start with the most frequent location in men. The lesions in our collection, most of these atypical melanocytic proliferations were located on the back. And as here you can see an example. This is a 63-year-old man. And as you can see, this is a solitary, ugly-looking lesion clinically, and dermoscopically it's definitely a melanocytic lesion with an asymmetric distribution of colors and structures, a little bit of regression on the right side, and a little bit of irregular network. This lesion, of course, it's sufficiently atypical to decide that the lesion should be excised, and histopathologically, as you can see here, there are really subtle criteria. So for the pathologist, it's not easy to call this lesion as a melanoma. But what do you think is this lesion? Definitely this must be a melanoma, and if we leave it there, of course, the lesion will develop enough criteria in the future to be called as a melanoma. This is another example. Clinically, the lesion is almost invisible. It's not really relevant, but if you look dermoscopically, the lesion looks very ugly with a lot of melanophages, a lot of pepper-like granules. So this is a almost completely regressive melanocytic lesion. And again, the diagnosis was atypical melanocytic proliferation. This is another type of patient. This is a younger patient, 47, and with many nevi. But as you can see already clinically, this lesion looks very ugly, composed by two parts, one more pigmented, one less pigmented. And here you can see that also dermoscopically the lesion is heavily atypical with a irregular black blotch on the right side and some kind of irregular network on the left side. Again, the lesion was excised and subsequent histopathologic confirmation revealed an atypical melanocytic proliferation, but again, this is a melanoma in my view. Okay. Of course, the back is not only a location for atypical melanocytic proliferations in men, but sometimes we can find them also in women, as is the case here, where we see again a solitary lesion, clinically already quite irregular, and dermoscopically even more irregular, even more atypical with an atypical network. The lesion excised revealed to be an atypical melanocytic proliferation, but again, in my view, we are dealing with a very initial melanoma. Okay, but most often women present these kind of lesions on the leg. And here you see an example, a very typical example of a solitary lesion of a middle-aged woman. When I see solitary lesions on the legs of middle-aged women, I'm increasing my index of suspicion by definition. And here you see a very ugly looking lesion clinically, and dermoscopically it's definitely a melanoma in situ. But again, for the pathologist it was not enough criteria to call it as a melanoma. Here another example, this older woman, and again a solitary lesion, clinically not relevant, but dermoscopically there is some kind of irregular network, and also a new clue that it's called wide skin markings. We found out that very often in melanoma we see these wider skin markings as compared to nevi or to benign lesions. Okay, so again, in my view, this is an early melanoma which was not called like this by the pathologist. And for the rest of the lesions, I will show you the next lesions in the next video. So bye bye and take care.